Got just about a minute after noon. I think we'll go ahead and get started. This is Brian Ittman. I'd like to welcome all of you to our first of the year 2016 webinar in the Southern California Regional Implementation Improvement Science Series. It's my pleasure to introduce a special guest this time, visiting with us for the winter from Stockholm, Sweden, Professor John Ovretveit. You have met John in the past or heard him speak. He's visited with us for the past 3, 4, I believe, winters. Especially those at UCLA and the local VA have had a chance to meet with him. John is Director of Research and a Professor of Health Innovation, Implementation and Evaluation at the Karolinska Institute in Stockholm. He's been studying patient safety, quality improvement, and more recently implementation science for a number of years, and has been working on issues related to the relationship between implementation and improvement, both on his own and with some of us at the VA. And, today we'll share the results of some of this thinking in a seminar entitled Faster Improvement with Adaptive Implementation Research.
Thank you very much, Brian, and welcome everyone. I'm assuming you've got the slides, so I'll go through quite fast and you'll be able to follow up on any particular items. I'd love to get to questions as soon as I can, and I've also realized I've probably done too many slides. Okay, thanks. What I'm going to try and do is help you with these challenges. One of them is a very practical challenge about changing practice and organization. Generally, in quality improvement, we emphasize more the technical rather than the actual politics and behavioral change aspects. Practical improvers are a bit frustrated with research for not answering many of their questions about will it work here and how much is it going to cost and what kind of conditions do we need to get the same results that they did in that trial. I'll be talking about that. If you're a researcher, and I guess most people on the call are researchers, some of the challenges that we face these days, and I say that because I think these have become much more acute over the last 5 years, is we need to reduce the time and the cost of our research. The challenge is finding time and funding to publish the results of our research. There is a basic question about what is our role for working on implementation. Traditionally, it's been what we call throw over the wall research, and implementation has been other people's problems. But increasingly, we're having to put in plans for, well, how will the research be implemented after, and potentially having an active role in implementation. There are also technical issues about documenting any changes that people have made to do with attributing outcomes, especially if you're not doing a control trial. Also generalization, which is saying the things and populations that we would expect to find the same results. Now I'll come back to all of these. What I won't be helping with is changing academic research criteria. They're not promoted or rewarded in terms of answering the questions of quality improvers, like, you know, will it work here, how much will it cost? Glasgow and colleagues have published a very interesting paper which they call 3R research. Is the research relevant, responsive and rigorous? And they often conclude that controlled trials are not so. For researchers, there's what I call the 3P review criteria. The criteria reviewers use for our proposals, publications and promotions. And the safest bet is to do a randomized controlled trial the more we go into information research and context and observational methods, the more risky it is. It also doesn't help where those practical improvements, if you're trying to do quality improvement in a setting, where it's really not possible to do it. Hopefully some of this will say a little bit about why the best intentioned and most conscientious quality improvement projects don't succeed. So, be relevant if you're evaluating an intervention, especially non-experimental approaches, or you want to design an effective intervention either for a trial or other sort of intervention. And also we'll touch on what is researchers' role in terms of actively involved in implementation. One issue we often face is in quality improvement is, well, if that's an evidence-based change, it was effective there, but it's different here. We're different in certain respects. But we don't have that problem here. I don't have the data to show that there is a problem. Or patients of service are different. It's not as easy. Or we have other changes and priorities where we are. What I'm going to cover is a case example looking at some of the problems. I'll look at some of the proven solutions for the problems and ask why not implemented. I'll talk about the general idea of fitting a solution to the context and show you models for that. I'm going to be talking about adaptation of the solution to the context. I'll explain that. I'm talking about how we might do research on the adaptations that people make, and talking about research better to answer those improved questions, not just did it work there. Look at the occasions for you. I need to say a few things about how I'll use the word. So I'm going to use the word intervention to cover both what is the before and after change, which is before the change we didn't use these methods for hand hygiene. After the change we do use these methods. And I'm going to distinguish that from what actions we take to enable people to consistent hand hygiene. That's the implementation action. So the new better way is, well, we follow hand hygiene guidelines, and what we do directly to enable people to take up new better ways through the implementation methods, training and feedback being one obvious one. Here to spell it out. We have poor hand hygiene, and we move to a time B where people do hand hygiene better. How does this happen? How do we make this switch? Well, there's an intervention concept, which is effective ways to improve hand hygiene. We have to do. Then there's a plan, but next take the plan for the actual implementation that's carried out. So we've implementation actions, and we can do these at different times, like we do the education, dispensers materialize on the units, patients begin to expect more, and so on. And we do these actions at different times, and ideally through those actions we get from A to B. And all done within a certain context that can help and hinder actions and moving from A to B. So that's kind of a map of some of the words and ideals I'll be using. As far as the conditions or the context for intervention, these various influences. For example, if we've got a really high workload, hand hygiene might slip. So if we really do want people to follow hand hygiene. You may have to adjust workload. You certainly have to make sure supplies of gel are regularly available. There may be an IT system change if you need to give feedback. Other conditions. And we'll see later that these are internal and external contexts that directly help or hinder. So, moving quickly on to the case example, here we've got Mary. Some of you may have met Mary before. Mary is stable when she's at home with her medications, incredibly independent. The aim is to maintain Mary at home, multiple morbidities, and a key factor in that is Matty, the black cat, who plays a really important role with the care manager. Mary's healthcare experience, a hospital admission, fracture, delays before she was admitted with radiology. Surgery wasn't done until 4 days later because of miscommunication. Patients were constantly changed in the hospital when they recognized Mary had a breathing problem. A hospital-acquired infection Mary contracted. She was sent home, no communications with the primary care physician or support provided. And they had to be readmitted quite soon after. And I won't get those, but you can see the before after in 6 weeks. The way says it all. Considerable cost and suffering that were needless. So, do you know approved intervention for the problems that occurred during Mary's stay or this whole escapade? For example, the constant changing of her medication in the hospital and sometimes the wrong medications. Do you know of an intervention that would help with that? What about hospital-acquired infections? How could have that been avoided in the hospital? Aftercare transitions. Well, the sort of obvious answer is, well, yes, there are proven known interventions that work for that. Medication reconciliation, there's a whole family of different ways to do that, with or without IT. Hand hygiene, well, standard bundles of interventions that are used for that. After, my favourite is Coleman's transitions intervention that uses a transitions coach at education in the hospital, and the transitions coach does follow visits and telephone calls, and it's actually pretty effective, being proven in a randomized controlled trial. So what's your experience, either as a patient or as a provider? Say we've implemented those solutions to prevent this, that this wouldn't happen here. You have effective medication reconciliations, and you would get those changes as Mary moved through the hospital. You do have effective hand hygiene compliance. Our care information is there within 2 days of discharge. And there is effective aftercare support, especially for older multiple morbidity patients going back home. I mean, you've been doing this consistently all the time for every patient. And that is what takes us to the whole issue of implementation. So, why are those proven interventions not consistently carried through? They're not implemented. What are those popular reasons? Oh, do we do a vote on this? Can we do that? Or
Easily.
not easily. All right. Well, for speed, I'll listen to the spirit of your voting, folks. What are the most common reasons, do you think, Well, actually, it's not a problem. This is just an extreme one-off event. So we really don't need to do anything. This is a very strange example. Actually, we're not aware of these proven effective solutions. We didn't know that something substantial we could do. We have to implement them, no problem, but it's just not a priority at the moment, and we don't have the time and resources to implement these properly. We don't have the skills and knowledge to implement. We could probably implement them, but we'd like to know what's the most effective way to do it, and we also need people in our organisation who can make sure it's implemented. Well, here's another explanation. Well, we know these are proven solutions elsewhere in controlled trials, but really doubt whether we'd get the same results locally. We tried this before on so-called proven interventions, and we often don't get the same results that they got at the test site. The reason we're not doing it is we don't have good research to show us how to implement it in our particular setting. So, which of those do you think is the most common reason for not carrying through implementation? I'll come back to that, and you might give your thoughts later. So, Quest. Why were, in my mother's case, in Mary's case, which was my mother, one of those proven interventions not implemented? Why did you have to go through all that suffering, and why have to lose all that money? It's taxpayers' money. Why were not implemented? What helped in widespread implementation? How to do implementation better? And can research have any role whatsoever in helping this? And so here are a few studies I've been involved in that have brought us to these PowerPoints. And what I'm going to do, so that the you can make a cup of tea or get to your next meeting or check microwave, few slides, I give you my conclusions. And this is a quick way of summarizing, and it might help you remember some of the points. Certain implementation does depend, yes, it does depend in part in having a proven intervention. That is really helpful and gives you a leg up, as it were, a quick start on making a change for a particular problem. Do we have a proven intervention for this problem? What's very important also is the gardener and how the change is planted and nurtured and time protected. This is where senior management comes in, protected from hostile other changes whilst you get the plant growing. But what's crucial is the soil with your local organizational environment, your local context, and the broader climate in the state and the nation affects it. And you can nurture pineapples in home in special climates, but not survive very long winter in Stockholm. And this is called the 10, 20, 30, 40 success rule. Essentially, 10% of your success depends on a proven intervention. 20% is your local management and leadership that sponsors and backs this and fast-tracks the change, especially if it's cross-department or cross-profession. 30% is having good professional project management, very basic issues of project management, but 40% depends on having a soil or climate that helps you implement these changes. And that's, as it were, to put in perspective some quality projects and why they don't go as far as we would hope. Often you just don't have the basics in place. We know beforehand that they're not going to be successful. Intervention survives first contact with context. That's why we need often to adapt the intervention to the context. But you will cry, if you adapt the intervention, be sure it's going to be effective locally. You're changing what was tested elsewhere. My argument is, have you ever seen an intervention that wasn't adapted? See, the thing would be if the adaptation actually more effective, so for this particular setting or population, and raises questions about how we know people have adapted and whether it is more or less successful. So, for example, Coleman's care transition, that's been implemented really for the last 15 years in lots of different places, and many adaptations. With those adaptations were even more effective and successful. Obviously, have to do linguistic ones if you've got a Latino population, for example. Another example is rapid response teams. A generic term for a whole variety of different kinds of teams that have been developed. And thank goodness they have been adapted for different organizations they're part of. So really, the key point I'm making is adaptation of proven interventions is absolutely fundamental to implementation. Why is it that implementation science has little to say in the field of adaptations? What I'm going to do is say a few words about what we do have to say and how you might be able to use what implementation does say about the subject. So the basic principle is things are very frail, weak structures. Crucial that allows us to be here doing these things now is we've been able to adapt to different environments from Africa to over the world, and we've been able to organize and work together. So the strongest survive. It's those who adapt appropriately that survive. A very good illustration of adaptation is, well, we know the evidence says that we should turn at-risk patients every 2 hours for preventing pressure ulcers. Realistically, we can only do it every 4 hours with our nurse staffing. If we get the same results in that way. Or you adapt the context, you simply increase staffing so as to be able to do it every 2 hours. Or you do both. And what I'm going to argue is we need the Goldilocks improvement fit for top, or F2. That is essentially we need to change intervention from the proven one in a way in which it fits the context, but it doesn't fit too comfortably, otherwise there won't be a change at all. To happen, the new way has to be different in some way. And what I'm saying is, it mustn't be too different and too difficult, otherwise it'll be rejected in the way that a donor organ is rejected. So here's an example of some of the research that's been done And what I'm saying is this idea about fit of the nation or the change of the context has been thought about. And these models can help you think about it, but it can also help you think about which data to gather to make an assessment of an adaptation. This is Greg Aaron's model. What it shows here, right in the center there, is you have the fit of the innovation to the system and the fit of the innovation into the organization. So you're in a context which is viewed to be like it could be a hospital within a health system, or it could be a unit within a hospital. And then your outer context could be like the whole health system, or it could be the hospital. And your innovation has to fit into the system, but it also has to fit and be accommodated within the organization. Part of what you do is to establish it in the organization in the right way. This is a more dynamic model. In some ways it's truer, but in other ways it's daunting or too difficult to think about, well, how on earth do we do this? And what it shows is the intervention has to adjust over time. Practice setting, and then you've got the wider setting or context. And what this model is saying is you have to keep adjusting to work in its changing context. So this is what's called a dynamic fit model. Chambers group that. Okay, moving on very quickly. The questions we then have is, okay, as if the adaptation is more or less effective. Also, let's do some natural experimentation, or rather harvest for different people doing their version, finding out which works better or which works best in which settings. And we do research that's lower cost and faster, especially to answer the questions of implementers, about time and costs and will it work for them. So it's a case example. I'll go through this very quickly. Hands hygiene compliance. Easy to fix, isn't it? Most effective intervention. Well, here is a really effective one. It's a very interesting example. Joint Commission, they pilot study of 8 hospitals using a variety of quality improvement methods. What they found was all barriers or hindrances to hand hygiene split into 24 different types of causes. Interesting was each hospital had different clusters. There were different issues that were in hand hygiene compliance in different hospitals, radically different. And within each unit, there were different factors. So what this approach did is it said, okay, find out what your main causes of not following hand hygiene are, and tailor an intervention. I'm now going on to the second study, which gets really interesting. What this study did is it made a web-based tool, and it said, here are 24 causes, do observations, fill in data of which are your big causes, and get a report back. And by the way, with the report, you'll get guidance about what to do about those top 5 problems. And the guidance is about what's effective ways to fix them. And what you've got in the pilots, you've got quite a significant increase. But very interestingly, in the mainstream organizations that just use the web-based tool, you got a higher, the improvement wasn't as high, but a very similar, consistent overall level, which is, you know, quite astonishing for this. And these are the causes, and this is the data collection that you simply do a quick data collection, enter in your observations, and get your reports, and work on the solutions on that. I'm now switch to a UK study, again, hand hygiene compliance. And what it shows, I don't know if you can see the colours, but light grey is 2006 and the black is 2009. And what we hear is one department doubling its hand hygiene compliance over that period. And one fall back slightly from 100%. Now, interestingly, this is the neonatal ICU, and had observed hand hygiene compliance of 100%, and it dropped slightly. Emergency department was one where compliance increased the most. What's the point that I'm making with this? Why am I suddenly switching to another study? One point I'm making is this study in the UK was able to look at the variations in hygiene compliance, not just the overall total. That then invites the questions, why differences between the departments? What's the theory? Are the differences? And a crucial question is, was it the quality improvement work in unit that was not done as well, or was it something to do with the conditions or the context in the unit? So, one of the lessons from this research is well, provide, supplied the data. So you're not getting researchers going in collecting the data. Researchers are looking at the provider's reports, or in the case of the Joint Commission intervention, they, in theory, would be more accurate because they're reporting the observations, you're collecting those data. The Joint Commission one enabled easy local adaptation, because essentially what they were saying is, take your intervention to improve hygiene according to what the barriers and problems are. Was a tailored adaptation. But the problem is we don't know the details of all 174 different versions for different settings. And if we knew that, we might be able to even fast-track it more by saying, oh, this type of unit in this type of hospital, this is probably all you need to do, is this intervention. So what the key point here is we need data to explain the variations. Control trials often give you good averages, but sometimes we're not able to do subgroup analysis, understand the variations. And what I'm interested in is outliers and what explains outliers' performance. Put it is, I think one of the biggest missed opportunities in HIV/AIDS research was I've done a fair bit of work evaluating HIV/AIDS programs overseas. A number of sub-Saharan African countries. I've asked this, and there's many instances of some prostitutes who've been tested for HIVs but are still alive and don't have a HIV issue later. And these are known examples in a number of hospitals. And research into those stream, as it were, of those examples and understanding, discovering, as it were, the outliers and understanding what's going on. This is one of the biggest missed opportunities I think there is in research, is looking at the variations and understanding the themes. So that's related to the whole issue about more informative research. I'll ask you a question, and I'm really interested in people's thoughts on this later. If doing an experimental trial, a randomized or a controlled trial, what's your thoughts about whether you should also drill down into explaining high and low outcomes or performance? Do you do this as a matter of course? Do you have the data to explain that? And I invite comments and thoughts on that. What I'm going to do now is focus on non-experimental or observational studies, and without controls, often single case or multiple case evaluations. And there would be, do you have any challenges? For example, can you describe intervention that people actually carry out? What's planned, but what do people actually do? What's the before-after difference? And I suggest some ways that will help you do that. Attribution is a problem for all of us. How do we know that any observed outcomes are outcomes of the intervention and not due to something else? Especially if we don't have good controls for that. List all the other explanations and assess their likely influence. And generalization that we do the worst on, which is, for example, in the discussions or implications section of a paper, practical implications would be in which settings or patient groups would we expect similar findings, and where is it that we're really very uncertain. I would suggest there may be different findings to those in our study. And that relates to, I think it's Green Glasgow's classic 99 paper on generalization. Increasingly, our research, is it used? Is it taken up by practitioners? If, why not? Well, I'll come back to that. And what I'm going to say is, for observational research, you need to do a lot of pre-study data collection planning, and that's where we mostly fall down in our research. We don't think it through before to say, these are data we need to collect, not just data about outcomes, but about how do we need data to be able to document the intervention. Also, possibly data about context, certainly if we're not doing a controlled trial. So, again, because it won't be so quick to do the votes thing, I'll ask you to think about this. Imagine you're the head of a clinic. And what you need to do is enable physicians to follow antibiotic prescribing guidelines. Many prescriptions for colds and sniffles. Behavioral change techniques would be most effective. What's this behavioral change technique? Or is it going to give people a hard time or shout at them, follow the prescribing guidelines? And we use the same techniques in a federally qualified primary healthcare centre as the techniques you'd use in the vegan pediatrics outpatients. This is one of the things that implementation science can do for you. It can say, well, actually, who maybe need to get a life, but anyway, have spent a few years categorizing behavioral change techniques, and 93 of them we know quite a lot about which effective and we use when. So, out of a clinic, you have a menu and some head start on what would be the ways I could use to be more systematic and maybe more effective on this. There are 73 implementation strategies. If those 93 weren't enough for you, have a look at these. PAL 73 classification. But I find it very interesting that PAL mixes what I call direct interventions like education, audit and feedback with indirect context changes like capitated payments is one of the 73. And we need to distinguish those, but we can come back to that later. So the point I'm making is to document the adaptations, you can simply say which of the 93 we're using. You use a standard description that would then allow you others to compare your research with others who've classified their changes in the same way. As regards adaptations, you can use Sterman's model. It's part of the model which has ways to define who did the modification and what modified. So that gives you a head start on thinking about which data you need to gather to describe the adaptation precisely. As regards context factors, the number of models that you could use. One of the most popular generic model is the Consolidated Framework for Implementation Research. And in fact, on that one, there's a tremendous website for that approach, and you can look at the context parts of the website for some very good head start about this. I got that wrong. This is the one that was mostly done for looking at evidence-based nursing interventions. But one of the three things they look at is context, and they've got a well-developed framework for looking at that. Christian Helfrich and team have done what's called the Orca Readiness Scale that also is very useful. And there's the music and other ones. So what I'm saying is you've got a number of frameworks from which you can start to decide which data to gather about context factors that may be critical for implementation. Here's an example. This is the context. This is to give you a feel of what these do and what these look like. I'm going to move on very quickly because I'm running out of time. The thing I'll say here primarily is use a causal chain framework to do attribution so that, for goodness sake, don't go to the final outcome, but follow the changes to see if the earlier changes were followed through to the end. This is another model, another version of that. This one has got context, and you can see you can collect data about these earlier stages. Now, Proctor, very useful implementation, and this will help you to detail. She has 8 types of implementation outcomes that you could collect data about to check whether it's implemented before you then check, have this happened, before you then go to client outcomes. And it's worked through that causal chain that allows you to do better attribution of outcomes to implementation. Now notice this two-way road, and that was my enlightenment 4 years ago, seeing that two-way arrow. Of course, adaptive implementation. The implementation outcomes achieved go back and choose another strategy or change your strategy. And leads, really, adaptive implementation research. And what I'm going to say is, plan data to document the adaptation and the context, look at implementation outcomes, then do distribution. I won't show you the full model of that because I want to pause for Ian's comments, but to spell out some of the implications. For you doing experimental evaluation trials, what do you think about identifying and explaining the outliers? Do you have the data to be able to do that? I'm very interested in what you have to say about that. Or is your job done when you report the average and say, generally it seems to work to this extent effectiveness and control for the other explanations? That's all you need to do. Just do one of these. As those of you doing observational studies, how are you planning using your existing data? And are you having to resort to the if all else fails, our cross-section of informed observers, what they think explained the change and how much it was the intervention and other things? They find out what implementers need to know. It's not just simply, did it work there? What other questions do they need answered from your research? And think about your responsibility for implementation, either during or after the research. And notice here, in the Bible of implementation, Reach Brownson et al.'s classic text, this is what they say. Another essential component of implementation research involved enhancement of readiness through the creation of a collective climate culture in an organization community. Do you think it's just a Freudian slip that they've researched there? Or are they saying that you can do your implementation research without also actively enhancing readiness? Ask about that. I wonder what you say. Anyway, questions to you. Do you study implementation? What to do better in implementation? And also examples of experience you may have. I'll start there, Brian.
Thank you. So, let's pass the phone over so that Ibrahim can unmute. Does it also have the chat function available?
Yeah, it's available. Right, everyone should be indeed. So this one thing we need to ask you is that if you are not asking questions, please mute yourself so that we don't hear any background noise. And so you can either ask your questions on the phone or use our chat, and we'll answer you.
Floor open. Any questions or comments? Wait a minute before I ask mine. Okay, as those out in the audience are formulating questions, John, I have a couple. One is, what kinds of parallels could you direct us to in clinical research or other forms of research, so that when we grant applications and speak with colleagues whose major focus is internal validity and who view adaptation and modifications and deviations from fidelity as a sin to be avoided, but what can we point them to by way of parallels?
I think the easiest there would be to say in health promotion and health education, public health literature, there are a number of studies where discussing and studying adaptation is more accepted and more standard practice. Very good example is colleagues at Washington University St. Louis implementing evidence-based interventions for mental health. And they did what they called cultural adaptation to different ethnic groups for the mental health program, and well reported in that literature. And there's a whole, used a systematic method to do cultural adaptation. There's a method that is really very rigorous and thorough, planning and testing cultural adaptations of different interventions. Well, this research is simply not known by those reviewers, and a lot of it is outside of strictly medical need and health services research. One other general point is think about physicians out an intervention with a patient, not to. Think about how they adjust dose. Part of it is following a systematic method for weight and sex and adjusting. But part of it is trial and error. The patient coming back saying, oh, it knocked me sideways and I stopped taking them. Well, let's do it this way or let's try another. Patient is common. And what does control trial and other research have to say to guide individual physicians, especially in primary health care, to make those adaptations? And their data in the medical control trial is different patient groups and then adaptations that were carried out or they rigidly enforced the protocol. And for me, what's interesting about controlled trials is how they make that protocol stick. That's implementation. That's clever. And to really expect everyone else to go to those lengths to implement that intervention.
Other questions, comments? We have a quiet group today. Again, I have a follow-up that I'll insert during the silence, and that is, it sounds as if the need for systematic framework and forms of guidance to guide the adaptation, such as a cultural adaptation example, is behind the list of research agenda items. So if the field were able to develop, algorithms for which we could focus our fidelity efforts, it's not fidelity to the one version of the model, but instead fidelity to this decision rule. It says if your setting looks like this, then adapt in this manner. Does that sound right to you, and are you aware of any work in that direction?
I think that's a really interesting idea, and it invites people to, let's get going on that one. And I really do think that cultural adaptation is really too systematic, rigorous. But anyway, it's a good template or model to start from. What I would say is, if you did do such a thing, I think you would provide implementers with much better guidance. It would be a very useful and welcome thing for a lot of implementers. And it would allow implementers and others to build on that. If you followed through that process, you would be able to improve the way that you do adaptations. Whereas at the moment, it's unspecified or undocumented. So I really like that idea. I think the only downside is that I suspect there would maybe have to have a variety of different systems for doing adaptations, depending depending on what sort of intervention you were doing. For example, if you're doing changes in a long-term nursing facility, it may be your approach. Well, supposing you're doing a bundle of interventions to prevent falls in the facility, you choose effectively which would be most likely to be most successful in that facility. The approach that you did to that would be different to the you would use to adapt an electronic medical record system in an academic medical approach, but there may be different systems.
It seems like is a target for the development of frameworks that would cover those different factors and provide guidance and what to attend to.
And it's also a hypothesis for testing. Would it need to be different? Why don't we just use the cultural adaptation approach?
Question that came in through chat that I'll read for the benefit of those on the phone who can't see it. Actually, if you could scroll back up to the top, there was one that came in first.
Right before it.
Hang on. So the question is, thank you for your time and the excellent presentation. In regard to the HIV example in Africa, did you examine the outliers, and if so, what did you learn?
No, it's still a brilliant. I mean, why don't you do it in LA? In fact, I'm also certain that you have people who've contracted HIV/AIDS, and their counts haven't gone up, and they haven't gone into AIDS. And big differences between the takes for people to go from HIV positive to AIDS. Well, into that. Has someone done that already? It's not something I've looked into. But it's a general principle.
Next question came in via chat. How do we reconcile the potential core philosophical differences between adapting interventions, based on the talk that you gave, versus community participatory research, where one develops the intervention with the community?
Did I say anything about how you did that? I would absolutely say you have to involve the people locally. Another way to put it is that a combination of part of that systematic approach is systematically to involve local people with local knowledge in contributing to making that adaptation. And that leads us into a whole nother subject, which is partnership research. I'd love to talk about another time.
That, too, it seems to me, could be incorporated into this idea of a set of algorithms or framework, guidance for adaptation, that it's not only how to respond to specific features of the environment in the context and modifying an intervention, but also how you go about making those decisions. It's not the researcher's responsibility to assess the local setting and determine what that means for adaptation, to work with those who really know the setting.
And all I'd say, last comment, is we need to use and think about a lot about politics, negotiation, personalities, power. All that is really important. So read Shakespeare, watch Donald Trump, follow the next one that comes. New Hampshire, yeah. How they do it.
A set of differences in the contents of our reference list for some of our articles. We're at the top of the hour. We'll go ahead and wrap up. John, I wanted to thank you again for your presentation. And any follow-up questions, I'll go ahead and submit them via email. And there'll be an evaluation on your screen. If you could please take a minute or two to complete that. We find it very helpful in planning future webinars. And we'll look forward to our next session. Thank you.